Sir, good morning, respected sir, my teachers, colleague. I'll be doing the clinical audit of June 2025. Starting with the total admission and discharges. Total admission in thoracic ward was 74 and discharges 57 with one discharge request in the month of June. And in cabin, there were 14 admissions with 14 discharges. So as the total number of cases that we did was 98, and as per the gender, there were 58 females and 56 females and 42 males in the month of June. And if we see the distribution as per age, the maximum number of the cases were from 65 to 79 age group, and subsequently lesser to that were 50 to 54 age group. As you can see in the chart, and this is the case every month as we see with our cases. So according to the procedure, the major procedures had maximum number this time, that is 52% of the cases were major, whereas 48% were minor cases. And the distribution as per system, the maximum cases, that was 51 normal cases were from thoracic system, and subsequently GI, breast, and other miscellaneous system had the given number of cases. So starting with the major thoracic procedures, there was one subject-wide unilateral thymectomy, which was converted to midline sternotomy. The case of which was also shown live in our channel. And then VATS left lower lobectomy, single case, VATS left lower upper lobectomy, and VATS right upper lobectomy, open right lower lobectomy of single case, open right lower lobectomy, and then left upper lobectomy 4 cases, wedge resection of right lower lung, sternotomy and excision of the intermediastinal mass, 6 VATS biopsy, 1 VATS excision of subpleural mass, and 4 left lower lobectomy, that was open left lower lobectomy was also at the month of June. 4 mediastinoscopic biopsy, 2 decortication, and 1 debridement and chest replacement was done. These are all the thoracic surgery procedures. And in GI system, the major procedures were Whipple's procedure 1, radical cholecystectomy with turbocharging of the right hepatic artery in the case of CAGV with artery involvement. The presentation was done some days back also. Lap cardiomyotomy with DOTS fundoplication, total D2 plus gastrectomy, right hepatectomy with cholecystectomy, transverse colectomy in one case, and right systemic posterior sectionectomy in single case, LAR plus ileostomy, and palliative ASIA in the single case, open cholecystectomy, lap cholecystectomy with bilateral mastectomies, and laparoscopic APRs are some of the major GI procedures. And continuing with the GI procedures, the distal gastrectomy, D2 lymphadenectomy was also a single case was there. Laparoscopic deroofing of hepatic cyst, and 3 lap cholecystectomy, 2 Rix reduction lapoforectomy, and a single case of ileostomy reversal, 1 extended left hemicolectomy, 1 X-lap and cholecystectomy was done. 1 case of laparotomy with proximal jejunal resection with jejunostomy, and 1 case of diagnostic biopsy for undiagnosed ascites with coeli peritoneal mets, and 1 case of bilateral Rix reducing simple mastectomy with bilateral salpingo-oophorectomy was also done. And these are some of the minor procedures that we did. There were total 16 USC guided true-cut biopsy from the lung lesion, 11 supraclavicular lymph node biopsy, 1 tube thoracostomy, 1 breast lump biopsy, 3 resuturing from our ward cases, 1 PTBD, successful PTBD, 1 pigtail insertion, 2 incisional biopsy, 2 incision and drainage, and single case of sinus tract excision, drain insertion for SSI management and chemopathy removal. Looking at the morbidity and mortality, the total number of the grading was done as per the Clavin-Dindo complication. The grade 1 complication were seen in 16%, where 14% at SSI this time, and grade 2 complication was seen in 12%, grade 3 complication in 3%, and grade 4 complication, some sort of reoperation was done in 2 patients, and mortality was seen in 2 patients. And if we see the endoscopic records, total number of 81 bronchoscopy was done in the month of June, where 38 were male and 43 were female. And endoscopy was 61, colonoscopy was 19. There were single sigmoidoscopy, 6 OGD and dilatation, and EUS and F, total 7 EUS and FNEC in the month of June. So on our regular academic presentation class that we conduct, the presentations that were conducted in month of June were approach and management of COPD in 2nd June, which was presented by Dr. Vikas. And then we went to NAMS for live workshop at VATS workshop at NAMS. It was done by the whole BPKMCS thoracic team, and it was conducted for 2 days. And then in 8th June, pulmonary artery anatomy and anomalies of the left upper lobe was presented by me. And in 10th June, pulmonary carcinoid tumors with approach-based discussion was presented by me. In 13th June, in 13th June, a detailed presentation of ECMO was done by Dr. Vikas Pandey. And in 15th June, clinical audit of May 2025 was presented by me. And in 16th June, there was a National Association of Surgical Gastroenterological Society, upper GI and pancreatic surgery, CME session, along with the live surgery of the VATS cephalorectomy, was done by all BPKMCS thoracic team. And in 17th June, feeding jejunostomy was presented by Dr. Aishwarya Pun, a resident from another institute. And in 26th June, a role of vascular reconstruction in gallbladder cancer surgery was presented by me. And in 28th June, surgical approaches for liver resection was presented by Dr. Bikan Acharya. As a case of the month, I have taken the case of CA rectum, for which we did APR plus CA rectum with liver mets, for which we did APR plus metastasectomy of the liver along with the VRM flap. And it was done at the last day of the May 2025, but I've taken it as a case of the month for learning purpose. So starting with the history, 35 years male from Kawasaki presented with the painless bleeding during defecation 2 years back, alternating history of constipation and normal bowel habit, and no history of mass per annum. And after he visited the hospital, he was diagnosed as C. rectum with the liver mets, which was unresectable at initial, for which he was planned for palliative chemotherapy, where he was treated by M. Folfox 6 plus bevacizumab, and it was continued for 9 cycles. And he then underwent CT scan, which was then followed by MRI liver, as it showed the decreased enhancement of the liver mets. And divergent colostomy was also done in between the treatment for the management of severe pain and then obstruction. And the FNAC of the liver mets, the decreased enhancement was seen, the FNAC of the liver mets showed no metastatic lesion in the liver. And he was then planned for definitive chemoradiation, and he received 45 gallium, 25 cycle RT for 5 weeks long course radiotherapy, along with the oral capecitabine, followed by again short course 5 days radiotherapy, along with the oral capecitabine, continued oral capecitabine. And then after that, he was evaluated for the surgery. And on examination, general condition of patient was fair, he was cooperative, ECOG was 2, 80 kg, weight of 80 kg and height of 168 centimeter. For abdomen, there was a colostomy present at the left side of the abdomen. There was no, rest was normal. And PR mass fell from 2 centimeters from anal walls. It was hard, fixed, as he had undergone radiation therapy as well. And there was a fistula present. Fistula is actually present at the 2 sites. One is shown in the figure as and one was in the 2 o'clock and another was in the 9 o'clock. So his pre-op labs were essentially normal. And on CCT, there were fabricative changes in the lungs, and there was a mass present at the rectum, distal rectum, along with the liver mets. So these are the initial CT scan. And after 5 cycle chemo, the CT scan was done, and we showed the decreased enhancement in the liver, but the residual disease in the rectum was there, which was further seen by MRI. The disease was locally advanced at the initial time, and we can see the mets as well, the liver mets in the CT scan. So, sorry. So this was further the MRI liver was done at this time. The FNAC was done. We showed no metastatic lesion in the liver. So these are the report of the MRI liver after the neoadjuvant chemotherapy. So he was diagnosed at the C rectum with hepatic metastasis, and extralevator APR was performed with hepatic metastasectomy with VRM flap closure of the perineal wound, and there were multiple liver mets and multiple liver mets inside the OR that was seen, and there was hard fibratic post-radiation changes in the pelvis with a mass palpable 2 cm from the anal verge and 2 fistulas opening at 9 and 2 o'clock position. So this was the colostomy site. We did the marking at first. Initial marking was done. So this was the site of marked site of the VRM flap that was to be harvested later on. So intraoperatively, we can see this is the intraoperative video. This is after the metastasis.
This is colorectal liver metastasis. So अब यो हामीले चाहिँ लिभरमा चाहिँ we have removed the segment 4A of the liver and along with gallbladder and block. And this was done anatomically because we tied the segment 4 vessel right here. You can see here, this is the vessel, and the hepatic vein was along this side, along this plane, a Cantill's line, that was also being ligated separately. Okay. So there is another one, small lesion was here, so we did poise resection of that small lesion. Thank you. Right.
So this was the liver bed that was after the resection of the tumors, and this was the perineal wound. We had to go far from the fistulous opening. This was the white perineal wound that was the extralevator, also because of the extralevator dissection for cylindrical specimen. So it was later.
This is the rectus abdominis muscle. Supraepigastric artery was ligated here.
Paramedian incision.
Border of the rectus muscle, we can see the
and the flap along with the freedom muscle.
tendinous insertion of the two muscles. So you can see here the inferior-epigastric vessels that is supplying the flap. So this inferior-epigastric vessel is the supplier of this very particular flap. Okay, and we are going to put the VRM flap. We are going to push it towards the outside, and finally we are going to close the defect in the rectum and pelvic diaphragm.
This was a small video clip taken from the mobile phone after the tunneling of the flap and positioning the for flap for the closure. The final report shown was like this. The flap was used for the closure of the perineal wound, big perineal wound. So this is the cylindrical specimen that we had resected out with the extra levator dissection, and this is the metastatic lesion along with the resected of the segment 4B, 4A and 4. And I'll be starting with some literatures on management of the perineal wound after the APR. So colorectal cancer is one of the most common malignancy leading to with the being the leading cause of cancer-related death. And APR and pelvic examination surgeries are still the gold standard for the lower rectal and anal cancer, and even for the severe inflammatory bowel disease, and also as a salvage surgery for recurrent or persistent anal cancer. APR is being done, which was introduced by Miles in 1908. And we usually resect the rectum, anal canal, and often the sigmoid colon with the en bloc ring or the perianal skin. And the perianal wound should be managed with, there are various techniques to manage the perianal wound that we'll discuss. The most common complications are even after the managing it primarily infection, abscess, wound dehiscence, and delayed healing, and perineal sinus can still be seen as a complication of the post-APR. And it impacts on morbidity, prolonged hospitalization, home care and medical cost, pain, and might delay the adjuvant therapy because of the wound complication. And the complicated perianal wound has shown to have a higher local tumor recurrence because the adjuvant tumor is delayed, and the worse long-term survival. The reason why perineal wound complicate after APR, it is reported to have a high complication rate, and the reasons why they complicate are usually because the pelvic is a dead space that is left after the rectum and anus is removed, and there can be accumulation of fluid, blood clots, which lead to the abscess and infection. The rigid bony pelvis, it prevents the easy closure or primary closure is very difficult. Sometimes it may break due to the high tension. And perineal wound management technique, radiotherapy, and primary disease type, they all directly influence the complications of the perineal wound. So management strategies that we have is the historical very old method is of primary closure of perineal wound, and which is still carried in most of the scenarios, especially in females. And in mesh closure of the perineal wound is also tried with the different types of mesh that I'll discuss. And then the flap closure and the vacuum assisted closure in the initial setting was done, but it is most commonly done for the complicated or infected wounds or open perineal wound after the APR. So I'll be start talking with the primary closure, mesh repair, and flap closure, and some literatures. Historical background, it was initially the perineum was left open and packed, and later on the vacuum assisted dressing was done after the perineum was left open, and later on the primary closure was started. The primary closure aimed to support the pelvic floor and ensure hemostasis, and the primary closure aimed with the 4 key principles, that is primary wound closure, closure of the peritoneum, and closed suction drainage of the pelvis, and perineal and pelvic room irrigation with active closed drainage. And the many literature have shown the 4 key principles should not be followed. You can see the evidence from subsequent studies. This is the RCT has shown that the closed suction of the drainage definitely improves the wound healing, but the additional irrigation and closure of the pelvic peritoneum is not found necessary. In fact, the closure of the pelvic peritoneum is associated with the prolonged perineal wound healing, and it creates a closed pelvic dead space which is prone to more infection. So later on, the primary closure with the omental packing, primary closure with open peritoneum was also started. So now the mesh enhanced closure. There are various types of mesh, that is absorbable or non-absorbable, and they have certain limitations, like the adhesion between the small bowel and mesh reconstructed pelvic floor can be there, and bowel adhesion and fistulization can also be seen, and it can be solved by biomaterials or the development of the new types of mesh that I talked. But the mesh enhanced closure, they reconstruct the pelvic floor by separating abdominal cavity from the perineal defect, and they reduce the complication from post-operative adjuvant radiotherapy as well. So some mesh that are being used in a third world country are sodium hyaluronate based membrane, that is seprafin, which acts as a mechanical barrier, especially beneficial in patients undergoing radiotherapy. And the various reports from Kusunike et al. From Japan showed the superior outcome versus primary closure. And in their reports, the mesh was sutured to posteriorly pelvic outlets or Walder's fascia, sacral periosteum below S2, and anteriorly vagina or prostatic capsule, and laterally fascia of the pelvic side walls. Another is the newer woman ocellular dermal matrix. These are the tissue engineered matrix and have shown the promising results as reported by the Chinese author Jia Gang et al. The biological scaffold, it is derived from the dermis, which is devoid of the cellular elements, are not prone to infection. They allow the cellular ingrowth, and tissue remodeling is also seen better seen. And the benefits are tissue compatibility and similar durability to the synthetic mesh. We showed that the primary closure versus the mesh closure had a significant, similar complication rate. But only thing that is prevented after the mesh repair is the perineal hernia, which has a rate of at approximately up to 27% in various centers. Truly miss. So the literatures have shown the reconstruction of perineal defects can be done, but the significant improvement from the mesh repair versus the primary closure is not seen in any RCTs. The complication after the mesh repair can still be the seroma formation, chronic perineal pain, and eventration or bulging or incisional hernia risk is always there. And there is a lack of multi-center RCT evidence, and that's why the mesh is still considered unreliable currently and not practiced routinely in many centers. So now the autologous reconstruction is another another method for perineal closure of the perineal defect, and it is still considered the gold standard for perineal reconstruction. Advantage being they are autologous, so no foreign materials are introduced. They fill the dead space very effectively with the vascularized tissue, and they are associated with the very low infection rates. And the common donor sites for these autologous tissue are rectus abdominis, which is the most commonly used one, and then the gracilis muscle, and then gluteus maximus muscles. The abdominal myecutaneous flap, which can be vertical or transverse, is widely used as a reconstructive method. So it can be oblique as orientation, which is also known as Tyler flap, or horizontal tram flap, which is commonly used in a breast setting, or vertical Viram flap, which is done in our case as well. And the flaps are raised based on the epigastric vessels and tunnel to the perineum. The most one side effect being the abdominal wall complications after the significant amount of the strength is being distributed to another center. So there can be incisional hernia, parietal wall weakness, or abdominal wall hernia. So to reduce the donor side morbidity, there is rapid use of muscle sparing VRAM, where the well vascularized fascia, the skin, subcutaneous tissue, and fat tissues, along with the anterior sheath, are taken to the perineum. So another is the gluteus maximus flap. It can be unilateral or bilateral. So the drawbacks being it has a functional impact. That is, there is a reduced hip extension strength, or it can also raise to the posterior issue with the lordosis onto the unilateral ipsilateral side if done in the to the contralateral side if done in unilateral gluteus maximus flap. And It is an useful alternative, but it has a high morbidity, so the widespread use has been limited. So this is the BioPEX 2 RCT where the gluteus turnover flap after the abdominal perineal resection was done. It was a it was a paper from Turkey, and the results showed the gluteus flap is not superior to tram flap. It carries the tram or VRAM flap. It carries the more complications. So another is the gracilis flap. The advantage being it is a minimal functional impairment because the gracilis is a secondary thigh adductors, and the primary site is usually outside the radiation field. That is, the donor site is outside the radiation field, so it is not affected by the radiation. It is easy to harvest, suitable for unilateral or bilateral use, and it is popular choice, rapidly increasing popular choice nowadays, especially post-neoadjuvant radiotherapy. And the limitations being a variable skin perfusion, only proximal part has a reliable blood supply. And the whole flap has a limited rotation arc, so the dead space filling can be suboptimal as compared to the VRM flap. And there are some regional flaps that are non-adjacent flaps based on the name vessels. They are harvested. Some are the Singapore flaps, which is the raised lateral to the labia majora. Tissues are raised laterally to the labia majora and transposed medially, tunnel medially to the gluteus. And then lotus petal flap, as we can see in the figure as well. So this is the fat pad along as lateral to the labia majora is raised in a fatty female, and they are rotated to cover the dead space. The problem in this being also again the dead space filling may not be as optimal as to the VRAM flap. So there are other perforator flap, that is superior gluteal artery perforator, inferior gluteal artery perforator flaps, where it can require the muscle dissection, risking the pedicle injury and sometimes a nerve injury as well if the superior gluteal flap is raised. There are modified gluteal flaps where partial gluteus maximus flap or Bocola flap is taken, which balance the volume and donor side mobility, which is similar to the muscle sparing VRAM, where the very minimal muscle are taken from the gluteus. And then VY perforator flap and propeller flap, where it is very small for ideal for small secondary defect, that is perineal sinus after the sinus or fistula excision, but propeller flaps are not good after the APR. So the choice of reconstruction can be the various methods, such as the pudendal flaps can be chosen for the small defects, or these regional flap or conventional VRAM flaps can be taken for the large defect. And the flap selection should be driven by defect size, shape, and donor site, patient choice, as well as surgeon's expertise, comorbidities, and treatments. So there are other flaps, very many flaps mentioned in the literature, such as tensor fascia lata and VRAM flap. For the used dead space, the tensor fascia lata is very difficult to harvest versus the VRAM, but it has a similar efficacy in optimizing the dead space. Bilateral gracilis flap for the good muscle block. If the patient had undergone prior treatment, then the highly vascularized flap like VRAM flap can be used. Sometimes the choice can also be due as per the patient positioning. That is the position. It limits the IGAP and SGAP flaps needs the patient to be converted to prone position, which limits its use, favoring more towards the conventional VRAM flap. The current challenges is there is no consensus on optimal wound closure method. The decisions are widely varied as per the resection extent and radiotherapy use, donor site, and presence of stomach scars. The reviews are inconclusive, and there are very few RCTs available to review as well. And the NCCN guideline, they recommends the flap reconstruction for large defect or irradiated tissues in any cases. And most of the RCTs from 2003 to 2000, reviews from 2003 to 2012, they all support the VRAM flap with lesser complication and higher acceptable rate. So the new trends in perineal reconstruction is there is obviously a shift in surgical approach. The conventional open surgery has now been converted to the laparoscopic surgery, which preserves the abdominal wall integrity and preserves the muscles for perineal wound closure. And the adapted reconstruction strategies like muscle sparing or local flaps like gluteus muscle flap are being used to reduce the donor side morbidity. And then the perforator flaps with good advancement flap as well as the free flaps have been used by various authors to minimize the donor side morbidity and maximize the dead space filling and with a good acceptance. Thank you.
And the ignored patient, where nobody wanted to pick the patient carefully because he presented a stage 4. Besides that, the tumor was fixed, located at the most difficult part, that is the distal 1/3 of the rectum. So, as per the protocol, the chemotherapy was started because the lesions in the liver were large. The first message from this our case is that whatever is the stage, even the stage 4 can be treated with the chemotherapy first or simultaneously for the rectal cancer as well, rectal primary. So quite often what happens, the liver lesions either regress in size or become metabolically inactive or can vanish completely. So that's called the vanishing syndrome, the liver metastasis. So whatever, if there are the lesions in the liver, even if it's metabolically inactive, we have to resect it. Because you can, for quite sure, say that this is the remaining tumor is there or not. So the first thing that we have to know, despite the negative FNA that after chemotherapy, we took the patient for resection because tumor appeared large even despite the metabolically inactiveness and also negative of the cytotoxic report. So that's should be the first step of that. Whatever is the result, we have to resect the tumor first. Second, when we have to consider for the resection of the rectal cancer. So in this scenario, if we are considering for the synchronous one setting, surgery of both the liver and the rectum has to be irradiated first because he had the T4 lesion in the building. So therefore, it's not wise to consider for the rectal surgery simultaneously if the rectum was not irradiated because of the T stage or N stage of the lesion. So the approach was quite good. We did the chemotherapy first, then the chemo radiation for the rectal cancer. And after that, the patient had the fistula. We are not quite sure whether the fistula are malignant fistula or because of the radiation injury, because the radiation toxicity, that the tumor perforate or even the healing happened and the fistula was formed. So whatever is the scenario, nothing has been left behind for him. Either to send the patient for palliative care or hospice care with only chemotherapy or some sort of the immunotherapy, etc., or to do something else. So I think from that point of time, looking at his case, we consider for the surgery that could be a wise decision, I guess. What's your opinion? So whatever we have this retrospectively reviewing the case first. So I think the surgery assist, what's your opinion? So we planned for the surgery. Was the judgment correct or not? We are still awaiting for the final judgment. But judgment wise, fistula, I don't know how many cases have been reported in the literature. Did you go through the literature regarding the similar case? I mean, presenting a stage 4 with the fistula between the rectum and perianal fistula related to the tumor. So we have to study again what the literature says. I'm also not quite sure, but I'm sure that before surgery I have used some of the literature where they suggest, in such context, the surgery is possible with the R0 margin, then you can go for the surgery of the rectal cancer as well. So therefore, the second message comes that in such cases, simple APR is never feasible, never justified. We have to go for the extra levator APR because the levators will be invaded. So far, the fixity is concerned. We don't know whether it's because of the tumor infiltration or because of the high dose radiation therapy that the patient received. Patient received perhaps 54 days. Radiation therapy. 54 right?
54 biceps.
54.
45 plus 9.
55 plus 9.
45 plus 9.
So it was in the with the option of the definitive chemoradiation. We didn't assume that the patient would be operated later on. So after that, so only the thing that we can do is extralevator APR. Not only that, we have to take a wide local margin of the perineal tissue that was done in the patient. So for the patient's surgical protocol or the chemoradiation protocol is concerned, I think we did a good job according to the protocol with the curative intent. You can see in the video of the liver surgery, wide anatomical resection of the lesion was done for the main tumor observed in segment 4, right outside. And the other lesions that were located in this, I think segment 6 or in the right of the liver, which resection was done also with the R0 resection margin. So, intraoperatively, the patient was tumor free from the liver side, and also we made the tumor free from the rectal side. The next thing is that how to close the wound. That's the debate that we're talking about. Definitely with a huge margin. So the dictum is that whenever you consider for the simple APR, I think the simple APR is generally what we do. We excite the internal anal sphincter, external anal sphincter. The levator ani depends upon the surgeon to surgeon, whether you are considering for upfront extra levator APR or you do not consider for extra levator, simply remaining inside. Do not excise the levator and only some fibers which are being attached to the rectum or the pelvis. Then at that point of time, simple closure is the best. That we have been practicing all the time. That we do not. So when you excite the levator ani in both sides, except in females, sometimes in females what's happening, the uterus is there, so you can put the uterus inside the pelvic cavity. The dead space will be gone. It will be easier because they are generally bulky, so it will be possible to close primarily. Otherwise, always some sort of reconstruction is required. So to our mind, we have limited knowledge about the flap closure, but so far in our unit, we have done perhaps this is the 4th case of the VRAM flap for the rectal cancer and 4 other things for the rectal cancer, and all of them were successfully treated. 2 patients are still under follow-up with more than 2 years of the follow-up recurrence-free. So I think this is a very good, so far this microvascular surgery, etc., it takes quite a long time. In a contaminated field, it's not wise to do that. The next, I think for us, only the VRAM flap is best because you don't need to change the position of the spine, single position, you can approach the patient. Besides, the patient had got the colostoma. This is another challenging part. We didn't go through the midline, we went through the right parallel incision because there is the colostoma in the left side. So this has to be also taken into point consideration. So we went. Our technique is a little bit different than has been as per the rule for the plastic surgeons. Plastic surgeons, they remember when we did this VRAM flap, we incise the anterior rectal sheath, right? And we leave like hooks to this side and this side. The anterior rectal sheath was, and like hook, it was lifted like hook. And only the rectus muscle was clear, right? So in a way, that the anterior rectal fascia is preserved, posterior rectus fascia is also preserved, and then we do except at the point where the pedicle and in the cutaneous and subcutaneous, which is being attached to the rectus muscle, which along with the fascia was excited. Rest of the part only the incision was made and the fascia was not excited. If you go through the classical text with the plastic surgery, they mention that the anterior rectus sheath has to take an en bloc with the muscle and with the muscle and subcutaneous tissue and skin. So it means definitely the patient will end up on a huge herniation. At that point of nothing to cover, we have to do the online means that's not good. So we think the online repair has to be condemned. So we left the patient as such. Somewhere, some places we closed the anterior rectus sheath. At some places where the bulk was taken for the muscle lifted with the myocutaneous flap, at that point with the fascia was excited. So this is good. So we know that in future, maybe patient will land up in the herniation. That's the future problem. So further, the next good option would be the gluteus maximus flap. I do realize that gluteus maximus is well developed, though it carries the morbidity because of the hip extension or flexion, etc. So that's another issue. So for us, I think the VRAM flap should be considered in such complex situations. The other option that have been given, that the literature review showed Dr. Sanjay mentioned each and every in very precise detail, so that I think is will not be possible at our setup. We are not very much like plastic surgeons. We are familiar with the VRAM lab as the option. We can reconstruct the breast tissue also like tramp lab. So we are used to the playing with the rectus muscle, so that reconstruction can be done for the baby. So, केही छ तपाईहरु भने जस्तो कि we did it हैन. So I think that should be for us. The option should be the VRAM lab is a very justified, very viable option in this complex situation. We are waiting for the biopsy report sometimes. Then next time we can come forward with the biopsy report solution. मलाई याद छ यो अहिले पनि तपाईँ हुँदैखेरि थियो पेशेन्ट त्यो मनोज पनि थियो क्या